Good evening, and thank you for attending AACP's webinar with Dr. Jarrod Cornehl, presenting Unlocking TMD Pain Relief, Integrative Strategies with PRF and Combination Therapies. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. Dr. Cornehl is joining us tonight from Florida, so we just want to give you a heads up that we're hoping the weather and internet continue to cooperate, as we could be interrupted. And of course, our prayers are with all of Florida. AACP has no conflicts of interest. Registrants can expect to receive a recording of the presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 business days. AACP's next complimentary webinar will be November 13th with Dr. Sadik presenting Pain, Helplessness, Suffering, Meaning, and Healing, Guidelines for Clinical Practice. Also, it's not too late to visit aacfp.org and register for our 39th annual symposium at the University of Notre Dame on October 25th through 26th. Dr. Jarrod Cornehl, a 2002 honors graduate of the University of Texas Science Center at San Antonio, is an accomplished restorative and cosmetic dentist and leading aesthetic medicine expert. He specializes in non-surgical treatments for TMJ disorders and myofascial pain, utilizing PRF, laser therapy, trigger point injections, and neuromodulators. As the lead educator at Advanced PRF Education, he trains dental and medical professionals in cutting-edge PRF techniques for facial rejuvenation and TMD pain relief. And with that, I will turn it over to Dr. Cornehl.
All right. Okay. Thank you so much, Shay, for the introductions. And thank you all for having me here tonight on this webinar. I'm excited to be here. For those of you who don't know me, I'm Jarrod Cornehl, a restorative and cosmetic dentist, and I've been practicing dentistry for the past 22 years, and I'm the owner of Dental Studio SF in San Francisco, California. For the past 10 years, I've been focusing on TMD and facial aesthetics. You know, I landed in aesthetics about 16 years ago in 2008, and I was going through probably my first midlife crisis. And one day I looked in the mirror and I realized that I could see lines and wrinkles. I could see crow's feet. And so I slowly started dabbling in aesthetics, not only for myself, but for friends, family, and colleagues. And it wasn't until a few years later that I kind of fell into TMD pain management. I was at a dinner party and one of my friends, she told me, "Hey, I'm overdue for my Botox treatment. I need to get in and see you. My migraines are coming back." And I looked at her a little shocked and I said, "What do you mean migraines? I didn't know you had migraines." And she said, "Yes, for the past 3 years since you've been treating me for my lines and wrinkles, I haven't had a headache or migraine unless I go too far in between my sessions." And so I would spend, the next few years trying to figure out that connection. And I'm going to share that with you later on this evening. Like Shay said, tonight we're discussing the latest advancements with PRF, blood derivatives, and TMD pain management. We're going to cover temporomandibular joint injection techniques with both liquid and solid PRF. And I'm going to provide some clinical insights into TMD pain management, utilizing not only PRF, but a unique approach with lasers, trigger point therapy, and botulinum toxins. Now, when coming out of dental school, I did like probably all recent or new grads and new dentists do. And when someone had TMD symptoms, I would prescribe them a night guard. And a lot of times that worked, but a lot of times it didn't work. And when it didn't, I'd spend more time speaking with my patients, educating them, counseling them, reviewing behavioral modifications, referring them to a physical therapist. And when that didn't work, I would punt them over and refer them to the dental school and hoping that they could get in and get some relief. So, I never knew why did some of these patients get better with the night guards that I was making them. But why did others not get better? What could I do to help these patients, especially the ones that have been suffering for many, many years? So, I went back to school. I tinkered around with the appliances, different designs, took a lot of occlusion courses, took a mini sleep medicine residency, took courses in airway, ortho, etc. And I was able to help more patients, but not all of them. The ones I could help, though, they were grateful and they started sending me their friends and colleagues who were also paid patients. And they seemed with each referral, each of their symptoms kept getting more and more severe. So I kind of evolved into this combination approach for those pain patients, where we're using lasers, trigger point therapy, and therapeutic botulinum toxins, and using PRF, our blood derivatives, for TM joint injections. So where traditional treatments with oral appliances didn't take care of their pain, I started evolving into this approach. Or maybe those patients, or some patients, they weren't willing to try an oral appliance. They were bad sleepers. They couldn't sleep with them in, or they've had appliances before, but it made them feel worse. Some of them weren't ready for larger procedures like orthodontics or partial or full mouth reconstruction. Or what I started seeing is they would not accept another new appliance. That severe oral facial pain patient that has been to, 12 different providers. They've been to their physician, an ENT, a neurologist, physical therapist, acupuncturist, chiropractors, massage therapists, you name it, and 6 or 7 other dentists. And they show up with a Ziploc bag full of appliances or orthotics, and they're just desperate for help. They just want relief, and they want their daily quality of life to be improved. They need to get better. So whether we begin with this approach or use it in combination with patients, when patients aren't getting better with traditional methods, we can build their confidence and then go on this journey together after to figure out the why. Okay. So we know that these therapies that we're going to show today, they can fairly quickly get our patient out of pain. That's when we can gain their trust, right? And then go on that journey together. And for all of you, that journey is going to be a little different. Depends on your practice philosophy or model. Okay. So I'd like to dive in and get started with what we're going to speak about today. To overgeneralize things, as you all know, right, there are 2 broad types of TMD, those primarily involving muscles and those primarily involving the joints. And we know that muscle disorders are far more common than intracapsular disorders. So I would like to start with muscles first. All right, photobiomodulation. I like to use my laser not only for those patients who are in acute pain, but even those who have been suffering chronically with pretty severe pain. And you can't even palpate their muscle without putting just a little bit of pressure, and they're already wincing their eyes. So we can take this laser energy, which is non-thermal, non-invasive, red and infrared light, to help modulate the inflammatory process in the body, improve cell function, and accelerate healing. I happen to use my dental laser. My dental laser is a dual laser, which has erbium YAG and Indy YAG, the 1064 Indy YAG. And we just need to know the target chromophore for any given laser's wavelength. So for the Indy YAG, it's oxyhemoglobin. And with the 1064, it's much longer wavelength. So we get much deeper tissue penetration when compared to a diode. I also have a diode, but I find that the results aren't as great as with a longer wavelength. And photobiomodulation is not new. Look at this trend. Each year, we get all these increasingly published articles and research, and it's growing. And I've had a lot of success in my practice with using the laser. So what I tell patients is that we're going to use this laser energy. It's going to target their areas of pain. It's going to increase blood flow and decrease inflammation, and start the healing process at a cellular level in the mitochondria. And we all know the mitochondria are the powerhouses of cells, and laser energy actually increases the production of ATP. And the more ATP we have, the more cell energy. It enhances our cells' ability to survive. It enhances operating performance, making our cells more efficient, and signals growth and repair. So I'd like to show you a video of a patient, a TMD patient, with doing photobiomodulation on them. Okay. First, what we'll do is we're going to go ahead and re-identify the trigger point right there that's causing her the most problems. So we've previously done a muscle and joint exam, and we've identified myalgias and myofascial points, and even the patient can help identify these for you. They'll come in with a handful of symptoms. And so we're going to use our laser, and we're going to use our pain handpiece, and we can place that directly on the skin with this laser. The patient's just going to feel the buildup of heat. And if they start feeling too much heat, we'll remove it off their skin so the heat can dissipate, and then we'll go right back down. And so we're delivering a certain amount of joules of energy in the trigger point complex itself. And then we're going to go north, south, east, and west of it. And we're going to deliver a different amount of joules in each of those areas. And with my laser, I do a second step. It has a little bit different tissue penetration depth. And so I'm going to switch over to a different handpiece here in a second. And this one, we're not able to place it on the skin because it would burn a hole in her face. And we need to keep it moving constantly, about the size of a dime or a nickel. And if that gets a little too warm, we either need to move a little faster, or we need to back our hand away from the patient's skin a little bit more. Okay. All right. So as we complete that treatment, these don't take but a few minutes, depending on how many muscles you're using. All right. Treating. Now, I know only, seconds have gone by, but what do you feel over here on your right side? Do you feel any different?
I do actually. It feels like the muscle's starting to loosen up a little bit. So I'm hoping that as time goes on, that it'll get looser and looser, and the pain will be hopefully gone.
Yes. So we could get some immediate effects with our laser. We're going to go ahead and treat her pain in her temporalis right now. We'll come back and ask her how, after a few minutes, how her masseter is doing. All right. Yeah, so just, seconds had gone by. Now, if we wait minutes and, towards the end of the treatment, we continue getting increased results. I tell our patients it's like magic, but it works on most patients, and almost every patient, not all, but almost all of them, we get some immediate relief. So when we're using our lasers, we've got to take in consideration the biphasic cellular dose response curve. We've got this therapeutic window that we need to stay within. If we deliver too little energy, it simply doesn't work. And a lot of people think, oh, I'll just go an extra minute, or I'll give an extra X amount of joules, and they fall outside on the other end of that therapeutic window. And that can be really bad because that can cause bioinhibition. So make sure we're staying within the therapeutic window. Know your lasers. Those that can treat pain all should have some pre-settings, and make sure you're staying inside that optimal window. okay, for biostimulation. All right. So that's what I would do, use a laser on our patients who are experiencing pretty severe pain. And that can help start making them feel a little bit better right away. The next combination that I will do is some trigger point therapy. My bias is that I do this with the delivery of my botulinum toxin, but you can also do it as a standalone, just like you could the laser, the photobiomodulation. But those procedures are more like physical therapy. You need several treatments a week for 6 to 8 weeks, depending on the case. And so it takes a lot longer to get that healing done than if we combine these three modalities together. But let's dive into the trigger point therapy. So trigger points are these hyper-irritable nodules or knots in skeletal muscles. Not only do they hurt when you press on them, but they refer pain to a distant site. If you take a peek at the trigger point complex on the right, not only can you feel those knots or see those knots there, but if you look on either side of those are the sarcomeres, and they're really stretched out. And you can feel them, they feel ropey or tendony, and they also hurt when you palpate them as well. So we can use a needle and mechanically disrupt these trigger point complexes. And you could do that dry needling, or you can use plain lidocaine, or in my bias is to do it at the same time, again, while delivering therapeutic toxin. Okay.
Today, we're starting with trigger point injections as part of our therapeutic TMD treatments, combination treatments with trigger point injections plus therapeutic Botox. So we've identified a bunch of trigger points, and we're going to go ahead and inject those today. This is just plain lidocaine, 1% plain lido, in a 3 cc syringe with the 30 gauge half-inch needle. And we're going to go ahead and enter into the skin, poke through the skin, and enter into the muscle. Okay. I'm going to give a few little drops of lidocaine here, okay, just to help soften the little burn. Sometimes lidocaine burns a lot on some people. Okay. And I'm going to place about a half a cc of lido before I start doing my little trigger point injections. Okay. I'm going to come in now, and we're going to slowly start moving our needle around, trying to hit these little nodules to release these little trigger points. Okay. Sometimes we'll get a little muscle twitch. How you feeling? Okay. Not really bothersome at all. Because we identified earlier, we're going to do this a couple little different areas. Right here, the fingers, that's where it's bothersome. So I'm going to come in from this angle and go ahead and give just a teeny bit more lido. Okay. And I'm going to go ahead and start doing these injections over here.
Okay. So we're working on her trapezius right now. We had identified another area there kind of at the angle there. We're going to treat that as well. And same thing, we're just using the needle as a scalpel, and we're trying to target and hit those trigger points. And we could get some immediate relief, even if we were just using dry needling. But the patient should also get some relief if we're in the right area, because we're using lidocaine in this instance. So,
okay. How are you feeling now? Good. All right. Do you notice any difference at all in your pain levels after us just doing those couple little injections?
It feels a lot better, actually.
Oh, yeah? Well, you were at a number. What was your number before?
Like between a 4 and a 5.
Okay. And now what would you say you are?
So this shoulder right here that's been bothersome is probably about a 2.
Okay, great. So we can get some immediate results just from finding and targeting the trigger points.
So, a lot of our patients will give us a number: 0, no pain; 10, the worst pain they've ever had in their life. When they give an average 4 to 5, I take that as a 5. So we got some pretty good results there immediately. And if we were to use the laser and we were to inject therapeutic toxin as well, we could get long-term relief for like 4 to 6 months. So we're also going to treat her sternocleidomastoid here. I'm going to put the chair back here in a second, ask her to turn to the side, and then she can lift her head off the headrest like that. So we can actually identify the SCM and grab onto it and then do our trigger point therapy. This was a pretty severe pain patient. Every muscle that we palpated and did the exam on was really bothersome. Her eyes were wincing with pretty much every one of those muscles. And she, since after doing the combination treatments, hasn't had migraines or headaches and no more head and neck pain she's going on about 4 months now. So she's doing well.
Okay, you can relax for me. And just look straight ahead. All right. How's that feeling? Did that help with your 2, or are we still about a 2? Okay.
All right, perfect. So we know there's well-documented referral patterns. This is a great manual to reference. We know that in the instance, like on the upper trapezius, if you look on the lower right side there, the referred pain can be located on the side and top of the neck, base of the skull, lower jaw, side of the head, triggering headache pain. And so we want to make sure that we are doing a complete muscle exam so we can identify these referred pain patterns, because otherwise the patient might point to their masseter, but the problem isn't in their masseter, it's in their trapezius. So we want to make sure we're identifying the muscles appropriately and coming up with the correct diagnosis. There's a lot of muscles that refer pain to the TMJ, or we'll call it TMJ/ear. So deep masseter, lateral pterygoid, okay? They also refer to some other areas, but I wanted to point out that these do refer to the ear and TM joint area. The medial pterygoid, and also the clavicular division of the sternocleidomastoid mastoid. So when patients are complaining initially of muscle pain and joint pain, I kind of take the joint pain in the beginning with a grain of salt. I want to first identify and see if they have myofascial pain and trigger points, and see if by treating that first, that doesn't take care of their joint pain. Not to say that people can't have true joint pain as well, but a lot of times it's mostly muscle. Kind of like we have referred patterns to teeth. Sometimes we look patients complaining of a toothache, and we look inside the mouth, and there's no tooth or periodontal problem. So the masseter refers pain to the upper and lower posterior teeth. That's the superficial masseter. The temporalis can refer to all of the upper teeth, anterior and posterior. And then our anterior digastric can refer to our lower incisors. Okay. Did you know that there's almost 700,000 teeth in the US per year that get root canal treatments when the source of the pain was not the tooth pulp? So as dentists, we need to make sure we're ruling out any tooth problems or periodontal problems before shipping them off to the endodontist. Or actually, I'd say if we don't see those orally, we want to start thinking muscles and start doing our palpation exams. Okay. Let's dive into what we call TMD or TMJ Botox, therapeutic Botox for clenching, grinding, oral facial pain, headaches, migraines, or even just to protect natural teeth or restorations that we're placing on teeth and implants. A lot of people think of TMJ Botox as just masseter Botox. And those that know a little more know that it's masseter and temporalis Botox. But it's actually tons of muscles in the head and neck can we treat with botulinum toxins and help our patients decrease their pain. And of course, then they become comfortable, they can think straight. Now they can go along with your normal treatment plan that you normally do for your practice. Now, if I accidentally say Botox, I'm not meaning the brand Botox. We kind of use that like a household name like Kleenex or a Q-tip. But there are 5 FDA-approved muscle relaxers in the United States that we can choose from: Botox, Dysport, Xeomin, Jeuveau, and Daxxify. But we could call those, neuromodulators, toxins, or botulinum toxins for general. Now, it wasn't until 1989, okay, that FDA first approved botulinum toxin for some medical conditions, strabismus and blepharospasm. And in 1990 was granted FDA approval for cervical dystonia. So as you can see, that's over 35 years that we've been using botulinum toxin, and it's the most studied toxin in the world, extremely safe. It wasn't until 2002 that we got our first aesthetic indication for moderate to severe glabellar lines. Those are the lines in between the eyebrows, your frown lines, or the 11s. And then 2011, we got FDA approval for the treatment of chronic migraines. Now, here's one of the mechanisms of action of botulinum toxin, and this is one that most people know about and talk about. Simply it's a acetylcholine inhibitor. So to make a muscle contract, the nerve sends a signal to the neuromuscular junction, and once that signal is received, acetylcholine is released, and then the muscle can contract, just like in the upper diagram on the upper right side. But when botulinum toxin is on board, you can see that acetylcholine is not released, and so therefore the muscle cannot contract. So it blocks the acetylcholine. This is what I spent years trying to find for my friend at the dinner party. These next mechanisms of actions as to why her botulinum toxin treatment in aesthetic areas was actually helping her with her pain. So we know here for botulinum toxin not only is a strong suppressor of acetylcholine, but it provides pain relief and anti-inflammatory effects by suppressing the secretion of other neurotransmitters and neuropeptides like glutamate, substance P, and calcitonin gene-related peptide receptors. For example, CGRP causes inflammation and pain that happens during a migraine, and it makes headache pain worse and causes headaches to last longer. It appears those that who have migraines actually have more CGRP in their blood. And then back to my dinner party friend, also the fact, a lot of these patients with headaches and migraines, they have hypertrophic corrugators, and those are the muscles that pull our eyebrow medially and towards the center. And look what's all around these aesthetic zones, the trigeminal nerve. And so the hypertrophic muscles are putting pressure on the trigeminal nerve, therefore causing the patient's pain. And so not only should we be looking at our head and neck, mastication, and cervical muscles, but also consider looking at the areas in the aesthetic zone, not that we're treating them for aesthetics, but we're treating them therapeutically to get rid of their headaches and migraines. And then, of course, the side effects are decreased pain, decreased headaches, decreased migraines, and they can look better too. Now, as you all know, muscles of mastication, but we also want to look at other muscles besides our muscles of mastication, and even besides our accessory muscles of mastication. So some of the cervical muscles that we always look at are splenius capitis, sternocleidomastoid, scalenes, occipitalis, trapezius, maybe even the rhomboids. In a lot of our pain patients, we're seeing that most of them also have pain coming from the top, five muscles: the trapezius, the splenius capitis, sternocleidomastoid, both superficial and deep masseter, and the temporalis. And then, of course, don't forget the glabellar complex here, where we got our corrugators, but also that trigeminal nerve runs through our frontalis and the lateral fibers of our orbicularis oculi muscle. So we also want to take those into consideration as well when we're treating our patients for oral facial pain. Now, when we treat, take a peek on the right side. When this patient starts clenching, you'll notice where he's bulking out a little bit more. And this is why you'll see from his right side to his left side, the markings look different. We don't just come in and do a cookie cutter approach to any of our injections. We are injecting with intention and following the pain. We want to do the follow the pain approach. So finding those trigger points, finding those myalgias and myofascial points, and targeting them not only with our trigger point injections, but also while we're delivering the therapeutic botulinum toxin. And here's a video of a treatment.
Got 10 units of Botox right here. We're going to deliver it equally into 3 spots here. Perfect. Good. And we can, with our Botox syringe, we could come back in and do a few more trigger point injections from the side here. Feeling okay?
Yes.
Good. Then we'll come over here. Perfect. Great. And now we'll go to your...
So we could go around. We're going to treat her fully for her TMD pain. So we're going to now treat her sternocleidomastoid mastoid. And if you see, I'm delivering the therapeutic botulinum toxin. And at the same time, with that same insulin needle, I'm going ahead and doing those trigger point injections at the same time. I don't typically do a standalone trigger point injection unless it's a one-off or at a future appointment. But I found this approach to be way more effective. We kind of throw everything at them at once, and they walk out of the office feeling way better than they walked in. And they just know they're in the right place, and they're off to starting the healing process. So then we can start talking about a long-term plan for them to keep them out of pain. But I don't mind, giving them this treatment as a Band-Aid approach so that they can actually have a better daily quality of life. Okay, so here's the sternocleidomastoid. I think we do a full treatment on this patient where we're going to now treat her masseter. Same thing with intention. We are finding those trigger points, and we are delivering the toxin as well as the trigger point injection itself. Need to know some anatomy here for depth and what muscles we don't want to be accidentally hitting to cause a smile asymmetry. And then next we're doing her temporalis in combination with trigger point injections as well. Anywhere they're having pain upon palpation, I usually do trigger point or poke them a few extra times in that area to see if we can't get some immediate relief of the muscle. And then last but not least here, for this patient, I'm feeling on her mastoid process. A little bit below that, I'm finding, again, the area of her splenius capitis where she was experiencing the pain. And then we'll go ahead and deliver the therapeutic toxin as well as a few trigger point injections at the same time. Okay, perfect. All right. And let's see what the patient has to say after this treatment.
Okay, so now we're done with your TMD treatment. We did some combination treatments for your muscles. We did photobiomodulation with the laser. We did some trigger point injections in areas where you had some myalgias and some trigger points. And then we also did your therapeutic Botox. I'm curious how you're feeling today after being poked so many times.
Much better. The pain is completely gone. And even being poked and prodded, I feel great.
Okay, perfect. Well, good. Would you say when you walked in here, you were at a 2? What are you feeling like now?
Oh, 0.
0.
I don't feel any pain at all.
Okay,
right now.
great. So that feeling should last for the next few days, okay? And then in about 3 to 4 days, your Botox is going to start working. Your toxin will start working, and it's going to slowly start increasing its effect for the next 2 weeks. At the 2-week mark, it's at its fullest. So you should notice your full results at 2 weeks. But let's give it another week to let some more inflammation go down. So at 3 weeks, we'd like to have you come back in so we can take a peek at you.
Absolutely.
Okay. Today, after the treatment, we say no exercising, no sleeping, no massaging the areas.
Okay.
Why? Exercise brings blood flow. We don't want to move the toxin to another muscle that we're not trying to treat. Same thing, we say no sleeping, pressure could move it. And obviously massaging can move it. The only one that we're really concerned for you that we did today is your masseter. If any of the Botox leaks into another muscle, your smile muscle, your risorius, we could get a temporary smile asymmetry, not the end of the world again, but we would try to avoid it if we can.
Right.
Okay. Do you have any questions for me?
No, it was great. Thank you so much.
Okay, you're very welcome. Thanks for coming in.
So don't forget to document. So we've got some, easily we can fill out this form. Here's some of the most common ICD-10 diagnostic codes for oral facial pain. There are others. And then also on this form, you can see on the right side where we would fill it in, there's a spot for trigger point injections. If I've done my trigger point injections, I'll put a check in that box, knowing that not only did I deliver the therapeutic toxin, but we also did trigger points at the same time. We have a lot of basic forms for documentation. If anyone would like these, just you can email me later, okay? We use digitally, and we can import the lot number and the expiration of the toxin that we're using, and as well as the units that we use in each of the areas. But botulinum toxin is not just for therapeutics, right? We know that we get some, we can do it therapeutically in the aesthetic zones. These happen to be the most common treated areas, and those are the most common areas where people get headaches and migraines. And so it's good to get good at treating for aesthetics as well, so that you can fully treat your patients. But we can do lots of other fun things with botulinum toxins, like treating hyperhidrosis, excessive sweating in the palms or underarms. And I wanted to run through a few cases here with you of some fun aesthetic things that we can do. We can treat their glabellar lines, okay, and their headaches at the same time. These are called forehead rhytids. If you also see in the top image how at rest she's got some pretty deep, severe static lines, and after treatment it gets way better. Didn't go all the way away, but with continued treatment over time, that will continue softening and softening. Okay. Here is our crow's feet or our lateral canthal lines. And we also have our a brow lift. So if you take a peek at this before picture, her brows are pretty flat. And for a more feminine shape, we can get a peek on that and raise the tail of the brow. And also for this patient, she was just excited that the heaviness on her eyelid was no longer there. And so you can see more of her upper eyelid skin. These are called bunny lines. That's the nasalis. These are vertical lip lines or water bottle lines. This is a case of mine that I treated for gummy smile. And even if the true diagnosis wasn't a hypermobile upper lip, in her case, she also has some vertical maxillary excess, we can still get nice results, nice enough so that the patient's, well, she was never going to get surgery anyways, but she's just ecstatic with the results of what we could do with our botulinum toxin. Depressors around the corners of the mouth give us this sad or grumpy look, and so we can make a smile more neutral or positive. This is pebbled or dimpled chin, and then also necklines and platysmal bands. But back to the masseters, sometimes we do it just strictly for aesthetics as well. We take a very round face because of the masseter hypertrophy. We can atrophy and slim these muscles down and give her a more youthful heart shape. And for those patients maybe who have a more masculine, a very strong square jawline, we can help slim that down and get a more V-shaped for her. Okay. All right. So now let's go ahead and switch over to platelet-rich fibrin for TMD pain management, whether our patients have, true intracapsular disorders, osteoarthritis, degenerative joint disease, or maybe they just have some pain upon chewing or palpation, popping, clicking, limited openings. We can use platelet-rich fibrin to help them. Before, all we really had was we could inject a steroid, or what a lot of people started doing was prolotherapy, where we actually injected a sugar or dextrose into the sore joint, and it acted like an irritant. And that triggered an immune response, and it created a lot of inflammation. And the problem with this is the patients a lot of times it didn't work, but even if it did, the patients, are in discomfort from the procedure for days to weeks, usually weeks. And so what if we could use our body's natural pathway of healing and bypass that inflammation, and we could use platelet-rich fibrin? So the goal of PRF is to concentrate cells, centrifuge to separate and concentrate the cells. There are fixed angle and there are horizontal centrifuges. Preferably from the research that's out, we want to use a horizontal centrifuge. This is the one that I use. It's horizontal, and it's actually the only one available, and that's FDA approved. But the advantages of horizontal versus a fixed angle is that you're up to 4 times, you get up to 4 times more platelets and leukocytes. You get a higher growth factor release. You get better separation between the cell layers, and there's actually less damage, less cell damage or cell death on the tube walls, and you get this more even distribution. Okay, so when we use a centrifuge, the purpose is to separate the cells based on density. Light cells, such as platelets, they go to the top. Heavy cells, like red blood cells, go to the bottom. And then the white blood cells are somewhere in the middle. So it gets a little bit tricky. You can see that the red and the white blood cells are pretty similar in size. But the advantage of PRF is that it's a fibrin matrix. You get this fibrin clot that forms. And in this clot, you get entrapment of cells, mainly platelets and leukocytes, as well as many growth factors in many different concentrations. And there's a lot of platelet-derived growth factor, or PDGF. And PDGF is the growth factor that's derived from platelets. Now, the 3 main growth factors that are useful in PRF is vascular endothelial growth factor, which induces angiogenesis. Platelet-derived growth factor, which helps with cell recruitment, helps wounds heal, helps vessels grow, and repair damage to blood vessel walls. And transforming growth factor beta, which helps with cell proliferation, regulates cellular processes, including growth, differentiation, and extracellular matrix formation and immunosuppression. And same thing here. Look at this trend. Each year, increasing publications. This is growing and growing and growing and becoming more clinically applicable, and lots of success with our TMD, our patients with true intracapsular or joint problems. Okay. So these studies, happy to send you some later on. Just send me an email or contact me. But these studies are showing that we get long-term analgesic effects. And not only do we get reduction in pain, but we improve the joint stability. We can tighten lax ligaments, help torn or lax ligaments, decreasing the popping and clicking, and even increasing range of motion. Okay. Now, how do we do that? Well, we've got our joint, right? We've got our mandibular fossa, our condyle, our disc in the middle. We've got our joint spaces. So there's 3 protocols with PRF that we use, and I just want to quickly go over those. The liquid PRF protocol, we get this increase in concentration of platelets and leukocytes in that upper 1 ml. We get a smaller volume but a higher concentration, and we might use this in our aesthetic practice when we're doing microneedling or maybe even some endo procedures. The solid PRF protocol, mostly even distribution of platelets and leukocytes in that whole upper 3 to 4 mLs or 4 to 5 mLs. Mostly dental procedures, soft tissue healing around implants, sinus grafting, GBR. That's what we will use. But for our joint injections, we're going to use the CPRF, our concentrated PRF, where we get this massive cell accumulation at the buffy coat. Right there where that 1 ml is, right at the red blood cell layer. And you can see right here, if you take a peek at the left test tube, you get this little layer. That's a little film that looks like sitting on top of the red blood cells. Those are actually your growth factors, and the stem cells and all the cells that we want for our treatment. And so we know what is in every single layer from Dr. Richard Myron's research at PRF Education. And we know that this buffy coat layer is where it's all at. So we're going to spin at the 2000 RCF for 8 minutes in a horizontal centrifuge, and we're going to get that little layer there. And we actually also would like this, if we're using the liquid PRF, we'd like this to clot in the capsule. And so we will grab a little bit of the uppermost layer that contains the fibronectin and thrombin. Those are clotting factors. And then we're going to blend that with the buffy coat layer where all of our growth factors are. And what we're going to do is we're going to, we teach injecting in 3 different spots. You got 3 chances to be intracapsular. And so we're going to go posterior to the condyle, anterior to the condyle, and then on the neck of the condyle. So, but first, before we get into those, we've got to draw the blood. So that's the first step. So we're drawing blood. And, you know, if you notice, not very much length on the tubing between where the needle is, the butterfly needle, and where we're putting it into into the tubes there. We need to get that blood drawn within 90 seconds before the clotting starts happening. And then also we want to make sure we're using the appropriate size butterfly needles. We don't want to use too small needles that will start damaging the cells as they're coming out. And so it's a little bit tricky. So we want to make sure we're not damaging anything. Next, we're going to start spinning it. And like I said, we're using the concentrated PRF protocol, 2000 Gs for 8 minutes in this horizontal centrifuge. You can see the little holders spin out and they go completely horizontal. And therefore, we can get that massive cell accumulation at the buffy coat. We can separate cells easier based on their density, and we're not damaging any of the cells either. Next, we're going to do our numbing. Okay, we're actually waiting. If you've ever got your patient numb and then they weren't able to get their blood for any reason, maybe they were dehydrated, they're a hard stick, or even they had a fatty meal for lunch and they came in after lunch, we're unable to use their blood. And so make sure we're doing the numbing while that's spinning so that we don't poke them unnecessarily. And I'm going to show you a little video here of the pre-numbing technique.
For the skin, that's what really bothers people, is when we poke the skin. So if we can get that area nice and comfortable, then they'll be practicing for their real TM joint injections.
So what I was saying there is, you know, I like to have the patient make sure that they can follow the instructions, open, close, stay open when I'm actually injecting. And that's going to be practice for when we're doing the intracapsular injections. The numbing is really just to numb the skin. That is what hurts when we poke them, when we use a needle. And I'm only using a 1/2-inch needle here. I'll be using a 30 gauge 1/2-inch needle, but I'm only using about half of that. I don't want to be intracapsular. We know that that the lidocaines or our local anesthetic are chondrotoxic. So we're actually using ropivacaine, 0.5% here to do our numbing, just in case any of that leaks intracapsularly. It's the least chondrotoxic of our local anesthetics. And we could send you that study if you like. But I aspirate and I'm going to just practice. I'm going posterior to the condyle. Okay. And once we're done, I'm going anterior to the condyle and then again on the neck of the condyle, really just hoping to get her skin a little bit numb so that we come in with our platelet-rich fibrin. She's nice and comfortable and she doesn't feel much at all, if anything. Okay. All righty. So now we're going to head on over to the other side.
All right. So let's do numbing on this side. One thing with the numbing, we want to tell our patients that they sometimes can get almost Bell's palsy symptoms if we hit their facial nerves. And so they can get an area in their eye where it starts watering, they're unable to close their eye, they start feeling a little droopy. We want to make sure they know that that's a possibility before we do our injections. It's temporary, it's just the lidocaine, it's normal.
All right. And then last, before injecting, we're going to collect the CPRF. if you take a peek there at this video, you can see that little layer there of cells. We actually need to go in there and declump them so that we can not only draw that up from a pretty large 18 gauge needle, but then be able to inject that back into our patient out of a much smaller needle, a 30 gauge needle. And so it takes a little bit of practice, and I'm going to show you how we're doing that right now.
At the buffy coat layer, you can actually see all the clumping of the cells right there where the plasma and the blood meet. Call it the.
All right. So I'm just talking about that. We're going to go ahead and take off the top there of the tube. I'm going to grab those clotting factors from the top, and then I'm going to head on down into that buffy coat zone.
Slowly and carefully start declumping the patient's cells here. I'm just smashing them against the side of the vial, the tube. And sometimes they're a little bit challenging to break up, okay? But I want to be able to grab these. The more cells we can get, the more effective our injections will be.
All right. So once I've declumped that enough, I'm still being pretty gentle there. I don't want to damage anything, but I'm actually gonna start drawing up some of the PRF here, and you'll notice my syringe in a little bit turns quite red. We actually know from the research that's been done that up to 0.3 of that red blood cell layer contains a lot of those growth factors that we would like to be able to inject back into our patient. And so these syringes can be quite red, and you actually want to have it with some red in there because that's where a lot of the cells are. Okay. All right. And then last here, we'll do our joint injection.
Start with the 3 different injections. Go ahead and open for me. Good.
So for sake of time, having her open and close, and I'm feeling the condyle when they open, and then I'm feeling right in front of her tragus, preauricular space where it dips in there, and I can access the posterior joint capsule space right there. And I do a little tapping on the skin just to help for distraction. And we're going to go ahead and aspirate and then deliver our platelet-rich fibrin into the posterior joint space here. And the patient should only feel a bit of pressure, okay? And we'll have her open and close between each of our injections. She'll just keep feeling a buildup of pressure. We want this to slosh around all over and get into every nook and cranny there. So that's why we have them open and close so many times. And then, so that was anterior to the condyle, and then here is on the neck of the condyle, aspirate and inject. And then we will head on over to, let's find out. Here's what she's telling us here.
Perfect. Now, it feels a little pressure.
Yeah, actually almost feels like bubbly in a sense. I think it's the preputus. I'm not sure.
Oh, okay.
I don't know.
And when you put your teeth together, does it feel a little bit different than it did before?
I feel like I can't touch them together.
Okay, great. Yep, that's normal. And so that's why we are always.
So what I was going to say there is that's why we're always treating our patients bilaterally. Even if they only have pain on one side, we don't want to send them out the door with muscles, fibers stretched out on one side, them unable to get their teeth together. That causes them more post-op discomfort. And these injections are very simple, very quick, and we send them out the door with a more balanced occlusion. All right, so kind of putting it together, we could also use our lasers, the low-level laser therapy. But if we're going to do it, we want to do it before the injections, or we should wait 48 hours later. We want to wait for all the cells to come to the site, turbocharge them with the laser. And if we do it too early, you might inhibit some of the inflammatory processes. So we do a couple treatments, about 6 weeks apart. We tell them no insets for at least a week after the injection. And, results can last for a couple of years. Now, that was liquid PRF. Now, with liquid PRF, we get growth factors releasing over the course of 10 to 14 days, so about 2 weeks. But we could also use a solid PRF, ALB PRF, where we get these growth factors being released over 4 to 6 months in the joint. If you see here, we're blending some syringes together. So what we've done is we've taken the upper portion of this tube, the platelet pore layer, and we're actually going to put it in the heater at 70 degrees Celsius for 10 minutes. It starts looking like a cooked egg. And this is our ALB PRF. And we can take this with the portion from the Buffy coat. We want to grab some of the red blood cells up to 0.3. This demo here is for facial aesthetics, so it does not have the red blood cells in it. But we blend those two together, and now we can take that into our joint space. Okay. So I see a lot of these studies are not using the concentrated PRF protocol, but we know from the studies that CPRF is 3 times more concentrated than IPRF and 5 times more concentrated than solid PRF. So just think about how more effective we are, and we're bringing our results to the next level by using the CPRF protocol. All right. So isn't this amazing? We could take the body's natural regenerative potential, concentrate it, and inject it back into the tissues. So not only can we do this in dentistry in our joints, but our orthopedic counterparts are doing this in shoulders and knees, etc. But we can also use it in dentistry for bone grafting, periodontal defects, improving implant success rates, aesthetic medicine for facial rejuvenation and improving skin health, and also in hair restoration, stimulating hair growth. So there's lots of great uses for PRF, and that concludes our webinar for tonight. I want to thank you all again for having me. I'd love to open this up for questions and answers, and after the questions and answers, I will share with you some learning opportunities and training opportunities, whether it's through, if you want to learn more about the PRF uses for dental or facial aesthetics or TMD pain management. Got some courses for you. If we don't get to your questions, please feel free to reach out to me. This is my personal cell phone. You can email me. You can send me a direct message on Instagram, and I'd be happy to send you PRF articles or answer anything that you have. So thank you so much.
Awesome. Thank you so much, Dr. Cornehl. It looks like we do have a few questions. For PRF therapies, do you have experience using Dr. Myron's scrambled eggs protocol? If yes, what scenarios do you find the most benefit?
I think you're referencing kind of what I said. Once we heat the platelet pore layer in the heater at 70 degrees Celsius for 10 minutes, I said it looks like cooked eggs, and maybe Dr. Myron said scrambled eggs. But yeah, we use this biological filler, and we can use it for many different in many different ways. Dentistry, they're using this. These are similar techniques for making graft materials or plugs and extraction sites for sinus lifts, etc. In facial aesthetics, we use it as an all natural biological filler to replace volume loss and build tissue over time. For medicine reasons, we're using it in joints, right? So for knees, hips, TM joints. So I think that's probably what you're referencing. So we can use it for many different in many different modalities.
Great. Indications for liquid CPRF versus biofiller?
You could use either. I think it just depends on where you are. If you're starting out doing TM joint injections, I think it's easier to do it with the liquid PRF. you get great results still with that. And it's a lot easier to push out of the syringe, and especially in such a closed, tight space in the intracapsularly. So you get a lot of feedback when you're injecting. It feels a little bit difficult to push even with the liquid sometimes, because we only have so much space in there. So if knowing that the growth factors are released for 2 weeks with liquid PRF and 4 to 6 months with our biofiller. Okay, so that's going to release the growth factors for a lot longer.
Okay, and are you injecting into the super and or inferior joint compartment?
Yes, we are trying to get the PRF all over. So superior joint space, inferior joint space, posterior, anterior, at the neck, the condyle, where the capsule attaches to the condyle. We are just trying to put all those growth factors and get them sloshed around in the entire joint complex to get the benefits of the PRF, where we get, helps build collagen, helps tighten the lax ligaments, helps repair damaged discs or ligaments, especially the disc, right? It brings angiogenesis to an area that doesn't have, blood flow. And so we're using it in all of those spaces.
Okay, and can you comment on post-operative discomfort?
Sure. Most of the time, our patients don't really experience hardly anything at all. They could be slightly sore for their next meal or two when they're chewing, but overall, the patients mostly start feeling better pretty immediately. If anything, we tell them that they could take like Tylenol, acetaminophen, if they did have any post-op pain, but we find that the majority of patients don't need anything at all. I think it really will depend though on how severe a pain they were in, but the majority of patients, they start feeling better immediately. They walk out the door even starting to say, yeah, something feels different. Well, their capsules have been inflated, and so but they feel the immediate difference and not much post-op pain at all.
Can you repeat when you use the laser at the PRF visit, before injection only or before and after?
Oh, yes. So if they were having true joint pain, and they were pretty acute, and I would consider doing the low-level laser therapy that same day, but I'm gonna do that first before my joint injections. Okay. If we do it after, we might inhibit some of the things that we're doing. So we're going to inhibit, we might inhibit the inflammatory process that happens, the natural pathway for PRF. And so we don't want to do it after. If we're going to do it after, we want to wait about 48 hours, and then we can come in and hit it with that laser and kind of turbocharge once all those good cells have been brought into the area. So do it before, not immediately after. Do it immediately before, but not after.
Okay. And we have an attendee that had this done at a course and says they had pain and stiffness and had some issues getting teeth together on that side. They're wondering if you think it's because only one side was done.
Absolutely. I kind of use analogy of riding a bicycle. You would never fill up, only blow up the air on the front tire, not the back tire, right? So we're doing the same thing with our joint injections. If we fill up one side, not only are the muscles stretched out on one side and not the other, but their bite is off. You saw it in the patient that I was treating on the video. She was only hitting on one side. And so that's why we always treat bilaterally, because we avoid the problem that you had when you only had one side treated. We see that a lot. Every time someone is having post-op pain, it's usually because the provider only treated one side, or they'll say, well, the patient wouldn't let me. So we need to educate our patients and tell them that, you know, we treat both sides, period. It's the same price. It's the same procedure fee. And so it's not like it costs extra, and it doesn't take but, you know, a minute longer.
And 30 gauge needle for liquid, what gauge for biofiller?
Yeah, so biofiller will not get expressed out of a 30 gauge needle. So we use a 25 gauge needle, and that seems to be the smallest needle that you're able to push out the biofiller. And it's a little bit more difficult still when you're intracapsular because of that. There's some back pressure. And it's more difficult than even doing it when we're using a needle on the, let's say, on the face for facial aesthetics. So, but 25 gauge, you know, at least a 1-inch needle.
Okay, awesome. And then before we end the webinar tonight, I know you had some courses you were going to share, and I think our attendees would love that info.
Yeah, absolutely. So if anyone would love to, you know, would like to know more about this approach to TMD pain management, we teach exactly what was talked about this evening. If it's a true joint problem, we teach you how to use platelet-rich fibrin and how to do the intra-articular joint injections with platelet-rich fibrin, both liquid and the solid form. We learned to use the laser for photobiomodulation in combination with our therapeutic toxin delivery, which includes the trigger point injections. And then, of course, you can learn how to do that as a standalone as well. We also learned how to do the preempt migraine protocol. That's FDA approved for migraines. These are upcoming courses. It's a 2-day, all of these next ones are 2-day hands-on live patient training courses, where the first day is all lecture and day 2 is all treatment. And overseeing everyone treating the patients that you bring, whether you bring, you know, a true patient or a team member that is a pain patient. A lot of dentists happen to be pain patients, so a lot of them will pair up with each other and be able to treat each other. And then next we have our biofiller and botulinum toxin course. And this is a 2-day hands-on course training as well, where we learn how to use biofiller using cannula techniques and foundational Botox. And then last but not least, if you, with PRF education, whether you want to learn dental, facial aesthetics, sexual wellness, or even get your team trained or yourself trained in phlebotomy and very specific to how with PRF, we can send out a trainer to your office, get your entire team nationally phlebotomy certified. And later in 2025, we've got a PDO thread lift course that we're going to be releasing, and also a lips mastery and lower face contouring, where we not only do lips, but we frame the smile as well. Thank you again for having me. It was great to be on here with you, and I look forward to seeing you guys hopefully in the near future.
Awesome. Thank you again, Dr. Cornehl. Have a great night, everyone.